Hello, my name is André Schmidt, and with me is Dr. Michael Pierkowski. We are here at the Park Hospital in Leipzig, and the plan is here to show you a patient with critical limb ischemia on the right side. On ultrasound, we have seen that the SFA is patent, but a lot of below-the-knee disease is expected. The plan is here to go right antegrade downwards, use a 4 French sheath, and then use very low profile balloons, the new one from Cook. It's a 3 French compatible balloon. Fine, to gain access, we thought to use the micropuncture kit from Cook. It consists of a 7 centimeter long one, a 21 gauge needle, together with a 4 French introducer. Well, puncturing here might be a little difficult because, as you can see, that the patient is a little bit obese. Tut das weh? Bei dieser Nadel merkt man gar nicht. So this is this blood here looks arterialized. Ja, nochmal ein blaues Tuch, ein schönes blaues Tuch. Ja, ein Klebetuch ist genug, ja. Okay. Schön ruhig halten das Bein, wunderbar, nicht? So here you can see the antertibial artery is patent proximal, but then has quite some disease. The peroneal artery has a shorter occlusion in the mid portion, and the posterior artery here is also occluded starting from the mid portion. This patient has several ulcerations at the medial malleolus, however, also at the tip of the foot. So, according to the angiosome concept, would be reasonable here to try to open up the flow into the heel area or malleolus area, which would be rather the posterior artery. Looks very calcified, but also the antertibial artery, although that dorsalis pedis is obviously a very small artery. Was meinst du? Ja, die auch, klar. Eigentlich hier in Science Dings einschließen. Nicht? Ja, reicht aber nicht. Ja, okay. So maybe if we can open up the antertibial artery and the peroneal artery, that would be successful. So one of our workhorses is the Hydro ST wire, an 014 wire, 300 centimeter in length available, and the tip is hydrophilic and polymer coated. We of course have to bring a bend into that tip to get from the popliteal artery into the antertibial artery. We're going to use this together with a support catheter, the CXI catheter from Cook. We usually take the 018 compatible one, straight version, 90 centimeter long. That should be enough here for that not too tall man here in an antegrade version. Geht's gut? Fancy? So this wire goes nicely here through that curve, followed by the CXI catheter. But now you can see that here it seems that there is already some stenosis in the proximal part where the CXI catheter doesn't go through. I try to bring that sheath a little further down. Musst du mal hier Roadmap raus. Ja, plus, genau. Ein bisschen eindämmen, ja. So as you can see here, there is already some stenosis here in the proximal part where this CXI catheter doesn't want to go through. And you can see here, the problem is here sometimes with the O14 that the push is maybe not enough in this morphology and this anatomy. But now with a little more pushing, you could see that it went through now. And now, after having traveled through the proximal part of the anterior, we go from contralateral oblique to ipsilateral oblique, and that calcium here will help us to guide our wire downwards. That is obviously not too difficult here. Shouldn't mistake that calcium from the calcium of the peroneal artery. That could be outside, however, now. Ja, was meinst du? Das könnte draußen. Okay, so this is not really, I'm not sure where I am here now. Maybe outside, maybe in a collateral. So let's take the wire out and try to aspirate through that CXI catheter. Nö. So, oder? There's some blood coming out, so I think I'm allowed here to inject some contrast. Oh yeah, there's the tiny channel, but also a tiny perforation, but it should be possible here to get the wire further down. So jetzt nochmal versuchen, das Bein ganz ruhig zu halten, mal Roadmap bitte. Ich flehe dich an. Okay, I think we change again to our Hydro ST wire. So this is here now the new 3 French compatible balloon from Cook. It's called the Advanced Micro 14 balloon. This is now a balloon with a diameter of 2 millimeter and a length of 100 millimeter with a working length of 90 centimeter. The outer diameter actually 2.5 French and with a hydrophilic coating, of course, in an over-the-wire version. So here comes the marker. I think it's safe to bring it down to this area here. Let's predilate down to that area. Mal den Roadmap raus, bitte. Wollen wir uns Ziele leisten hier mal, um das ein bisschen... Was? Unbedingt sogar. Rated burst pressure is here 16 atmospheres. Now I'm at 16. Tut das weh? Mhm. Bitte?
Die Dauer ist sehr blöd.
Das dauert zu lang?
Ja.
Naja, ist aber auch einiges zu machen. Wollen wir ein bisschen Schmerzmittel geben?
Das war besser.
Vielleicht besser?
NCP 2 Milligramm Mo. Gott sei Dank haben wir das Mo ja schon aufgezogen.
So predilation also in this area here, although there was not too much disease. Okay, I think we can go down a little further with the balloon now and use that balloon here as a support catheter. Was machen?
Möchtest du eine rote fahren?
Ja, durch den Ballon. So I'm gonna take that wire now out. Okay.
Ich habe hier mal eine kleine gemeine
Phänomenale. Eine Dartspitze. Fine. So After predilation, I think this is now easier here to maneuver the wire into the right channel, hopefully. No. Here, maybe. I think there is some kind of occlusion. Yeah, here the wire always goes out of the artery subintimal. Yeah, it might be difficult here to pass through. So maybe that's again outside of the artery. Yeah, I think we have here quite some perforation, and the only chance is here to go retrograde. Warte, der wird da nicht tief reingehen, ne? Guck mal, so. Okay, so this is our 4 French right Judkins catheter to snare the wire once it comes up from retrograde. Let's block it here, and we take that same wire now here to get through the dilator of that 3 French sheath. I take that same wire to go through that dilator of the 3 French pedal sheath retrograde up. Okay, so now we have access to the anterior, but actually this is not the right direction. What do you think? Is this the right direction to the anterior artery? Please do some injection. You are in my way. Oh. Yes, please inject a little bit. And yes, okay, so the wire nicely went directly through the lesion from retrograde into the right version. However, now we have a short wire here in place, so I'm gonna push my CXI catheter now through the lesion, which is very difficult because it's very calcified. But I'm happy, however, with this position. I'm going to take this wire out now and reinsert here now the Hydra ST to snare it. Okay, so again with the Hydra ST we are through that lesion, and next step is here now to snare the wire proximal, but first I have to take that angle out of the wire. Just a moment. Nee, der geht jetzt nicht weiter hoch. Ja, nee, kannst du mal weiter runter gucken? Stop. Okay. So snaring, of course, with the loop is not so easy, so therefore I try to get the tip upwards like this. Please continue up. Yes. Oh. Takes every. Ja, das ist jetzt zu spät. Okay. Warte. Kannst du mal gucken? Nichts. Okay, so, ja, da oben, mal ein bisschen vergrößern da oben und filmen. Ja. Okay, so now comes the snaring maneuver into a Judkins right catheter here. Please go in. No. But maybe we should angle. Can you take the C-arm into another, or torque that Judkins right? Yeah, exactly. To the arterial wall here, please. Torque it once again. Yeah, this is a good position. Leave it like this, please. Don't move it anymore. Warte mal kurz. Kannst du ihn noch mehr drehen irgendwie oder noch ein bisschen ziehen, ja. Wo sind wir da in der Vene? Nee, nicht? Wir sind da schon. Aber du musst ihn drehen. So, zur anderen Seite. Ah, hier, stopp. Warte. Kannst du noch ein bisschen drehen? Okay, so now the wire is in the Judkins. Now I'm gonna push it through the groin sheath up. Water. Now we can once again advance our. Now we can once again take our balloon, the advanced micro 014, over that wire, integrate down, and then take the CXI catheter out of the dorsalis pedis artery. Okay, so here comes the marker of the advanced micro balloon down, and I can further pull my CXI catheter until we think we are through the lesion. May you just push it a little further down, please?
Ja, das würde ich gerne.
Okay. Okay. We can also inflate that balloon here once to have an easier, to be able to get it further down. Tut das weh? 16 atmospheres. And now. Now this balloon nicely travels further down. Let's not inflate the balloon here because I'm not completely sure whether we are already too far down. I don't want to balloon that puncture area. Probably that's without risk here now, but I think now it's time to take that wire out. So we pull the Hydra ST wire now antegrately out and reinsert it now with a floppy tip looking downwards. Let's dilate once again also a little bit more proximal. Kannst du mal den proximalen Marker hier über den Ballon, den Patienten ein bisschen runterschlagen? Okay, let's pull back the 2x100 a little bit. Let's balloon here once again. Usually we take a 5-minute balloon inflation. Deflation time of that balloon actually
Ist gut.
very fast. Yeah, nice flow down to the anterotibal artery. Still a tiny bleeding, and maybe in fact that to me that distal area also looks now a little bit diseased, so why not take that balloon further down and also inflate in that area, huh? What do you think? Let's do this. Let's reinsert the advanced micro 14 balloon. Kannst du nochmal Plus drücken, mir die Dreieckspitze zeigen. Beautiful. Yeah, I think this is quite good. No? Yes. Shall we balloon further down? No. Okay, this is a very good flow now.